on to our next case. This was a cat that I saw that had a chronic non-healing wound over the left thigh and stifle. As you can see, the wound is covered by a granulation bed, but there is minimal epithelialization or contraction that is happening. So, what options do we have in this case? Before thinking of options per se, we need to take into consideration the location of the wound. This wound is located over the stifle joint, which means there will be a lot of mobility causing tension on any closure. Any closure has to take into account the full range of motion of the stifle joint and be able to account for this to preserve function of the limb. Given this, let's look at what options may be available. We could try to undermine the skin and close the defect, but given what we've discussed, we are unlikely to have enough skin to be able to preserve stifle mobility. An inguinal fold flap is something that we can think about, but if looking at the wound closely, we realized that most of the inguinal fold was involved in the wound and seemed to have been lost. Another skin flap is certainly an option, and this is what we went on to do in this case. You could argue that you could try to manage the wound a bit better and leave it to heal by second intention, but again, given the location and the risk of excessive contraction over the stifle joint, I would think that this is not really a sensible choice. In this case, we performed a caudal superficial epigastric axial pattern flap, and I'll go on to discuss this in a little bit more detail, but this is a really useful flap that can be used in a variety of different locations as we go on, and I'll discuss these as we go on. These are pictures taken from a surgical textbook, and you can see that this flap is harvested from the ventral midline, and we harvest it from the mammary tissue region. It's based on the caudal superficial epigastric artery that supplies the mammary chain. This flap can then be rotated to cover wounds on the flank or the proximal limb. This is a picture of this flap being used to cover a defect on the medial region of the thigh. Again, you can note the use of surgical drains to tackle any dead space. So looking at axial pattern flaps in a bit more detail, these are skin flaps that are based on a single cutaneous artery and vein that supplies a predefined area of skin. There are predefined axial pattern flaps in dogs and cats that have been identified. Because of the defined artery and vein supplying this area of skin, these flaps can technically be larger than subdermal plexus flaps and are considered more robust. However, these flaps do depend on a single vessel, and therefore any damage to that vessel during surgery can lead to very dramatic flap failures. This is a diagram that can be found in several textbooks, and this highlights the common axial pattern flaps that can be used in dogs and cats. And as you can see, their boundaries and landmarks are drawn on. It is crucial that these landmarks and boundaries are well known and understood prior to taking on any surgery. Again, drawing these out prior to making any incisions is very useful. Over the next few slides, I'm going to highlight some tips that I personally find very useful in optimizing my outcomes in such cases. Firstly, gentle tissue handling is essential. As this picture shows, I tend to use stay sutures, especially at the distal ends of the flap, and I avoid picking up the flap either using my fingers or even using forceps. I tend to use towel clamps, as we saw in the earlier pictures, when trying to decide where best my flap should lie. Towel clamps have very sharp pointed edges, and therefore they don't crush the skin, so there is less of a risk of damaging the blood supply. For subdermal plexus flaps especially, I try to include as much of the subcutaneous tissue as possible to ensure that I have got the subdermal plexus in my flap. Again, careful consideration of flap dimensions, especially for axial pattern flaps, is essential. And again, in the cases of subdermal plexus flaps, making sure that our flaps are not too wide or too long is very important as well. Careful skin apposition without inversion or eversion is essential for ideal wound healing. And this is something I'm very considerate of when doing extensive skin reconstructions. I usually close my flaps in 2 layers, using a buried cruciate pattern in the subdermal layer to bring the skin edges together and ensure that there is no tension on the skin prior to skin closure. The picture on the right shows a wound following just closure of the subdermal layer. As you can see, the skin is already closely apposed, and this is what I try to achieve before attempting to place my skin sutures. I then place skin sutures as a final layer of my closure, but as I said, there's no tension in this step at all. I usually use cruciate sutures, as in my experience, they tend to result in better skin apposition. As this picture shows, this is the final closure that I've done using cruciate sutures. Again, I also avoid using any tacking sutures or sutures in the deeper layers so that I don't damage the blood supply. The skin sutures are placed fairly loosely to allow for any skin swelling in the next few days so that it doesn't then go on to constrict the skin.